Hi, this is Jocelyn Jackson, and I'll be presenting to you infectious diseases with a focus on influenza. The World Health Organization states infectious diseases are caused by pathogenic microorganisms such as bacteria, viruses, parasites, or fungi, and the transmission of that organism or its products from an infected person, animal, or reservoir to susceptible host. Although infectious diseases can affect people of all ages, they have a particular burden on the young, especially children under 5, older adults, and ethnic minorities. Many infectious diseases are vaccine preventable, yet they remain among the leading cause of illness and death in the U.S. and account for substantial spending on the related consequences of infection. They account for 15% of all healthcare expenditures, costing $120 billion. An estimated 35,000 Americans die and 3 million are infected from drug-resistant bacteria and fungi. The CDC reports in 2014 there were 34.1 deaths per 100,000 persons due to infectious diseases in the U.S., and mortality rates were significantly higher among men than women. Although many infectious diseases have become less prevalent, they remain a significant threat throughout the world. Influenza or the flu is an acute, contagious upper respiratory illness caused by influenza viruses. There are 4 types of seasonal influenza viruses, types A, B, C, and D, and there are 2 main types of influenza virus, types A and B, which cause seasonal epidemics of disease. Influenza A virus is further classified into subtypes according to the combinations of the hemagglutinin HA and the neuraminidase NA proteins on the surface of the virus. It is usually clinically diagnosed through appropriate respiratory samples, and the application of a laboratory diagnostic test is required to establish a definitive diagnosis. Signs and symptoms include a sudden onset of fever, cough usually dry, headache, muscle and joint pain, feeling unwell, sore throat, and runny nose. Current conventional treatments include rimantadine and amantadine, which have become resistant to the virus, oseltamivir phosphate, also known as Tamiflu, which is a neuraminidase inhibitor, and zanamivir, which is also known as Relenza. Those at greater risk of contracting influenza are pregnant women, children under 5, elderly adults, individuals with chronic medical conditions, and those with immunosuppressive conditions. On average, influenza leads to more than 200,000 hospitalizations and 36,000 deaths each year. Because it is so common, incidence is seasonal. However, approximately 8% of the U.S. population gets sick from the flu each season, with a range of between 3% and 11% depending on the season. Children through the ages of 17 are more likely to get sick from the flu each season. The picture to your left demonstrates high influenza activity in the red and darker orange areas of the United States. In 2016, the annual direct cost for hospitalizations and outpatient visits is estimated at $10.4 billion. Acute respiratory infections, like the flu, are the 8th leading cause of death in the U.S., accounting for more than 56,000 deaths each year. During the 2017 through 2018 flu season, there were an estimated 79,000 deaths. When an influenza virus is introduced into the respiratory tract, it attaches to and replicates in epithelial cells in the trachea and bronchi. Viral replication occurs, which destroys the host cell. The new virus particles emerge from the cell membrane and are released with assistance by neuraminidase to infect surrounding epithelial cells. The infected cells are then forced to die and shed, causing a local inflammatory response, along with systemic toxic symptoms like fever, soreness and pain, and decreased white blood cells. The first natural product for influenza is elderberry, which refers to several different varieties of the sambucus tree, which is a flowering plant. The most common type is Sambucus nigra, also known as European elderberry or black elder. They are widely used in Europe, Western Asia, North America, and North Africa. The dried berries are a purple-blue color due to the high levels of bioflavonoids and anthocyanins. Elderberries are used traditionally to treat influenza, colds, upper respiratory infections, sciatica, headaches, dental pain, and nerve pain. Elderberries are used for influenza because the flavonoids can disarm the neuraminidase enzyme of flu viruses, preventing them from penetrating healthy cells. It has also been shown to inhibit the hemagglutination and the replication of different human influenza viruses. The first study for elderberry aimed to assess the effect of sambucol products on the healthy immune system, specifically its effect on cytokine production. Sambucol is a standardized elderberry extract with antiviral properties. This study used blood from 12 donors who participated that were young, healthy students with no inflammatory conditions and currently receiving no medication. Peripheral blood was taken from each subject and diluted in a 1:1 ratio with phosphate-buffered saline. Monocytes or white blood cells were separated from the phosphate-buffered saline and incubated with different sambucol preparations. They included sambucol elderberry extract, sambucol black elderberry syrup, sambucol immune system, and sambucol for kids. 4 different sambucol preparations and LPS, a known white blood cell activator, were added to the white blood cells and then stored until the content of cytokines could be determined. After evaluating the effect of different formulations of sambucol on the induction of inflammatory cytokines, results showed that the sambucol in all 4 preparations significantly stimulated the production of the inflammatory cytokines IL-beta, IL-6, IL-8, and TNF-alpha by normal human white blood cells. However, sambucol elderberry extract had the highest stimulation and was shown to activate the immune system by increasing inflammatory cytokines production. Limitations on this study included a small sample size, and the study only looked at effects, so there was no placebo. No side effects were reported or safety issues reported, as this was done in vitro. The second study for elderberry investigated the efficacy and safety of oral elderberry syrup for treating influenza A and B infections. This was a 4-site, randomized, placebo-controlled study done in Norway on 60 patients aged 18 to 54 who demonstrated respiratory influenza symptoms. A standardized elderberry extract, or sambucol, was used. The syrup contained 38% of the standardized extract plus small amounts of raspberry extract, glucose, citric acid, and honey. The placebo syrup had an identical appearance and taste, supplied in the same type of bottle. Subjects were randomly assigned to 2 groups and received either 15 milliliters of elderberry or placebo syrup 4 times a day during meals for 5 days. The first dose was given within 48 hours of the onset of the influenza symptoms. The symptoms that were assessed included aches and pains, degree of coughing, frequency of coughing, quality of sleep, mucus discharge in the respiratory tract, and nasal congestion. The Visual Analog Scales, or VAS, was used at baseline, had the endpoints 0 equivalent to no problems and 10 equivalent to pronounced problems. Results showed that in the elderberry group, most of the scores were near to pronounced improvement after 3 to 4 days, while the placebo group reached this level after 7 to 8 days. A complete cure was achieved within 2 to 3 days in nearly 90% of the elderberry group, compared with at least 6 days in the placebo group. This showed elderberry syrup is effective against influenza A virus infection, and duration of the illness can be reduced by 3 to 4 days with elderberry syrup compared with placebo. Some limitations on this study were that it was not double-blinded, and the study involved only adult patients who were otherwise healthy and did not include high-risk patients. There were no adverse side effects reported. The third and final study for elderberry was conducted to evaluate the efficacy of elderberry extract in relieving symptoms of influenza in a slow-dissolve lozenge. This randomized, double-blind, placebo-controlled trial was conducted during the flu season by medical personnel in China. 64 volunteers ranging from ages 16 to 60, presenting flu symptoms for less than 24 hours, and otherwise healthy individuals were included in the study. Participants had at least 3 of the following symptoms: fever, headache, muscle aches, coughing, mucus discharge, and nasal congestion. patients were assigned randomly to two groups and received either a proprietary elderberry extract lozenge or a placebo lozenge that was identical in appearance, taste, and composition. Each treatment lozenge contained 175 milligrams of elderberry extract. Patients were asked to take 4 lozenges a day for 2 days and were asked to self-assess and score their symptom improvements on the visual analog scale 4 times a day during the 2-day treatment. Symptoms were assessed at the onset of treatment to investigate if the two groups were clinically comparable at the start. 0 was equivalent to no problems and 10 equivalent to pronounced problems. Results showed that after the first 24 hours of treatment, the elderberry extract group showed significant reduction in all symptoms, whereas the placebo group showed no improvement or an increase in severity of symptoms at the same time point. By day 2, 9 patients in the elderberry group had no symptoms. 19 showed relief from some symptoms and had only 1 or 2 mild symptoms with a VAS score equal to 1. In the placebo group, not 1 patient achieved complete recovery and only 5 showed improvement in 1 or 2 symptoms. These results demonstrated that the proprietary elderberry extract can rapidly relieve influenza-like symptoms. Some limitations on this study were that it did not include young children nor anyone with other chronic illnesses, small sample size, and a short duration. During the study, no patients reported any adverse side effects. My evaluation after looking at all 3 studies is that elderberry is not only safe but effective in cells where it was shown to stimulate an immune response, and in humans where it was shown to rapidly reduce influenza-like symptoms. Standardization for elderberry used in 2 of the studies was at 38%, showing it was effective at this amount to get the content of flavonoids. Dosing, however, should be taken often at the first sign of symptoms until there is some relief. As influenza viruses become more resistant to antiviral drugs, this can be an effective alternative. The second natural product I'll be discussing is Panax quinquefolius, otherwise known as American ginseng. It is an adaptogenic herbaceous plant from the ivy family, widely cultivated in eastern North America, Canada, and China. It is closely related to Korean ginseng or Panax ginseng. Traditionally, it has been used more in Asian herbal medicine as an herbal tonic, improving immunity, but pharmacological effects of ginseng have been shown in cancer, diabetes, cardiovascular disease, and have been used for promoting immune function, central nervous system function, relieving stress, and for its antioxidant properties. It has been used for influenza because of its major bioactive components called ginsenosides or ginseng saponins that have immunomodulating effects. It has been shown to enhance immune responses like immunoglobulin production by lymphocytes and stimulate cell-mediated immune response and natural killer cell cytotoxicity. Also, the polyfuranosyl pyranosylsaccharides is reported to be effective in adult upper respiratory tract infections. The first study for American ginseng was a randomized double-blind dose-finding 3-arm trial conducted to document the safety and tolerability of 2 weight-based dosing schedules of American ginseng. The study was carried out in Edmonton, Canada on children aged 3 through 12. Children were randomly assigned a weight-based supply of ginseng. This ginseng product was a standardized polyfuranosyl pyranosylsaccharide extract of American ginseng. The weight-based approach for the standard treatment arm was 600 milligrams 3 times a day for day 1, 400 milligrams 3 times a day for day 2, and 200 milligrams 3 times a day on day 3. Low dose received half the standard dosing, and the placebo group also received a weight-based corresponding aqueous solution. They used the Canadian Acute Respiratory Infection Flu Scale, or CARIFS, a quantitative scoring sheet to measure severity and duration of upper respiratory tract symptoms. The results were that children in the standard dose group were the sickest, having the most symptoms as measured by their baseline CARIFS score. However, they recovered as quickly as the children in low dose and placebo groups. Some limitations on this study included it was a small sample size, and there was possible confounding due to children using outside natural products at the same time. Also, this was a short-term trial due to the age of subjects, and they did not want to expose a cohort of children to long-term daily use of American ginseng for months. No serious adverse effects events were reported. The second study was done to see if regular supplementation of CVT-E002 or cold FX during influenza season would be effective in the prevention of upper respiratory infection in influenza-vaccinated community-dwelling seniors. This was a multi-center randomized double-blind placebo-controlled 3-arm trial with 603 seniors aged 65 years and older recruited through 4 different health regions in Canada. Cold FX is a patented polyfuranosyl pyranosyl saccharide-based extract of American ginseng, and the study compared the effects of 2 dosages of Cold FX, 400 milligrams a day or 800 milligrams a day, and the placebo. Treatment consisted of taking 2 capsules of steady treatment 2 times a day for 6 months following the onset of the influenza season. During an upper respiratory infection, subjects completed a daily log of the severity of their symptoms on a scale of 0 to 3, 0 equal to no symptoms, 3 equal to severe symptoms. They evaluated daily symptom scores for all days in which a score exceeding 4 were reported and added up to calculate the total symptom score, or TSS. The primary endpoint of the study was the incidence of acute respiratory illness referred to as a laboratory-confirmed clinical upper respiratory infection over the 6-month study period. This was defined as a positive result for any of the viruses tested in the swab and defined by the presence of at least 2 of the following symptoms: cough, headache, sore throat, and fever. Reported upper respiratory infections were also evaluated using a validated symptom self-assessment tool called the Jackson criteria. The seniors were considered to have a Jackson-confirmed upper respiratory infection if the TSS over 2 successive days was greater than or equal to 14 and at least one of these symptoms was present: sore throat, runny nose, nasal congestion, and cough. The results concluded that there was no significant effect on the number, severity, or duration of lab-confirmed upper respiratory infections, but the number of Jackson-confirmed upper respiratory infections per subject was found to be significantly reduced in those taking Cold FX. Some limitations for this study were the use of outside supplements with some subjects and a lower than the usual incidence rate of influenza reported at the 4 sites during the study. Also, the delays in collection and transportation of swab samples may have contributed to the low rate of laboratory-confirmed infections. There were 6 adverse events reported that could have been related to the treatment, including gastroenteritis, ataxia, asthmatic bronchitis, appendicitis, pulmonary embolism, and cardiac arrest. The third and final study was done to investigate the immunomodulatory effect and anti-apoptic effect of ginsenosides on avian influenza-infected human endothelial cells. Human umbilical vein endothelial cells, or HUVECs, were treated in cold 70% ethanol for at least 2 hours, and cells were then infected by the influenza virus to encourage interferon-inducible protein 10, or IP10, cell death. And after 1 hour, the virus was removed, and M199 med with or without ginsenosides was then added to the cell cultures. There were also mock-treated cells used as the control. These cultures were treated for 24 hours, and then the fluid residue of the cell cultures was collected and the IP10 level was measured by enzyme-linked immunosorbent quality, or ELISA. The results demonstrated that ginsenoside metabolite protopenaxitrol showed significant suppression effect on IP10 production upon the H9N1 influenza infection through increasing the MIR15B gene expression. Data from cell analysis and tunnel content showed that ginsenoside could protect endothelial cells from H9N1-induced cell death and DNA damage. Some limitations on this study were they used only 1 strain of virus, and the cells used are unknown, whether from mother or baby. Not much information was given as to how many cell cultures were used, and no adverse effects reported, as this was a study done in vitro. My evaluation after looking at all 3 studies is that American ginseng may be effective, but in an extract form like that of Cold FX. It may have helped in reducing severity of influenza symptoms in older adults, and dosing was tolerated in children, but there needs to be additional evaluation with regard to pediatric upper respiratory tract infections. Dosing requirements also need to be extensively tested more to prove its efficacy. Overall, American ginseng needs more vigorous tests and a standardized amount for safe use in the future to be a natural therapy worth recommending. Here are two other alternative therapies for influenza. First, oscillococcinum, or OSCI for short, is a homeopathic product made from a specific extract of wild duck's heart and liver that is marketed to help reduce duration and severity of flu symptoms if taken at the first sign. One observational study done in Italy found that OSCI had a preventive effect on the onset of respiratory tract infection episodes, and that treating patients with OSCI lowered the cost for the National Health Service. Garlic, the bulb of garlic, Allium sativum L, contain many properties, one of those being the sulfur, which has antiviral activity. Two independent researchers in Japan and Romania found that garlic is able to protect living organisms from the influenza virus. Here are the references used in this presentation, and thank you for listening.